done a fantastic job. Before we start with the panel, I just wanted to remind you to get off the internet if you're on it to allow for the bandwidth for our 50+ virtual attendees. Sounds like that's something that we need an education from the wanted to make sure that that's it. And then the second is if you kind of needed to take a break, there are also restrooms in the back. So if you just go out there, you can avoid the rain on the back as well. And the good news is we'll have more networking. So once we're done in the next 55 minutes after the panel, we'll have time to network. So definitely looking forward to that part. Now, without further ado, we have an amazing group of executives here. They are industry leaders in their own area, and they have very diverse perspectives. And we're very lucky to have them speaking to us to a variety of topics. I'll start with Alicia. She is hailing from Scripps. She's a Senior Director of Revenue Cycle Access at Scripps Health. She brings a non-profit health system perspectives to our questions. Dr. Kintzele is the Director of Provider Relations at Vituity. He's also a physician partner. And he brings the physician partner perspective to our panel today. Doug is the Vice President of Revenue Cycle at Palomar Health. And he brings the California Healthcare District and Hospital perspective. Gerilynn is the Vice President of Revenue Cycle at Sharp Healthcare. She brings the integrated delivery system perspective and hospital billing perspective. And Terri is from UCSD. She's the System Director of Patient Revenue Cycle from UCSD Health, and she's bringing the combined patient billing office and teaching facility perspective. Now, I have a very important question to all of you, and we'll start with Alicia. What is your favorite holiday tradition?
So I think it's quickly become this elf on the shelf. Oh, sorry about that. So I think it has quickly become the elf on the shelf. However, I will admit we do have to set an alarm because I forget.
Thank you, Dr. Kopp.
Yeah, of course, the No Surprises Act is kind of a big issue we're dealing with right now. There's a number of moving pieces, and I'm not sure if many of you heard the American Medical Association and the AHA filed a joint lawsuit today to challenge the dispute process. So lots of things going on with the NSA and what they're doing.
And your holiday tradition for your family?
Oh, I'm sorry.
I
thought the question was, that's it.
This is committed to our career.
Oh, I'm sorry. I just heard the question. I don't have any particular holiday tradition other than trying to get together with family as much as possible.
Very nice. Very nice. Doug?
Balance. Yeah, that's true. Forcing our kids to watch Elf.
Gerilynn?
Okay, I'm testing this out. Is it working?
What?
Who said what? I actually have a very special holiday tradition that actually started when I adopted 2 girls in the house. And we decided that we needed to start a tradition amongst our family. And what we do now every year is we all get together and we go to like a thing that does city governments. And so it's a Christmas thing. So we all go in and we pick one ornament that we think kind of means something to us for that year. Bring it home, we sign it, and we date it. So now every year at Christmas, I pull them all out and I line them up for each of them so they can see, well, I remember when I was playing the violin. Just has turned into something that now all of our friends want to go with us. They're like, when are you going to go get your ornaments? So I have ex-boyfriend ornaments, I have sister ornaments, so it's really fun. So if you have little kids, I think you should do it.
Thank you, Gerilynn.
We'll do this right before the meeting. When my came from a divorced family, and as the kids got older, we want presents for Christmas, right? So if my mom was just going to give this money, she's going to make us work for it. And I can remember one year that she put our money and rolls and spit them in there. Oh my God! To us to dig in this kid litter to get our money. So it is the one thing that has stuck in my mind for probably will be forever. That's yeah. And I mean, she's frozen it in a loaf pan in the tank of the toilet and gave us a treasure map to go find it. I mean, all kinds of. I mean, it's every year we would just never know. I mean, and we cringe like our money this year, you know. So that's our tradition.
That is a good one. So we're going to talk about a lot of different things in the next hour. So before we did our little short, we talked about a lot of different regulations and rules that passed this year, at least in the last 2 years, that's going to go into effect in 2022. Which ones are the ones that keep you up at night the most? I think we've learned Dr. Powers already. Alicia, I'll start with you.
Oh, certainly price transparency, making sure that we're able to meet that.
That's good feedback.
Yeah, I would say it's unfortunate. We have such a short runway to meet these regulatory requirements. And so we've had to shift our priorities. We had to make sure that we've got the right people working on this around the clock. Making sure that we get this implemented right and on time is going to be critical.
Thank you.
I would say pretty much the same. I've been on a couple of panels nationally this week, and folks see this whole initiative as a political move towards a single payer system, not beneficial to the public at all. And from a orchestrating the process connectivity with physicians that may not be put together geographically or systemically. There's a lot to it to get it right, and the emphasis as always is on the feedback to the provider, which puts us in a bad place. So I think that's part of it. The other is that as an industry, strategically, we all are trying to play catch up on our long-term strategic plans for the COVID pandemic, and this is very distracting and can be very hampering some of the expedience we would be hoping for to align ourselves with a plan and pick up to that time.
Thank you. Gerilynn? Oh,
and I can hear myself.
Jeff is the boss.
Okay, is it good? Yeah, let's do that.
When you're holding it, put it straight up, like up down.
Yes.
Like you're a celebrity singer.
All right, well, I'm going to echo what was already said, but the other things that are happening with Research Sharp is we actually just signed an ethic agreement for all of our platforms. So this is going to be a major conversion for us over the next 33 months. Huge, huge, huge. That, and I think I'm sharing this only because it's similar to what my peers say, is that most of us have seen our financials age and increase. I hope there's no payers in the room. I think payers have really enjoyed the additional funds that they've been able to keep. And now that business is picking up and there are more claims to pay, I get the sense that they're feeling like, oh, we like those profit margins, and how are we going to keep those profit margins going forward? So it's that payer-provider relationship that gets a little sticky too. I mean, again, with my role at UCSD, I think what keeps me up this night is, how are we going to explain this to the patients? How are we going to help them navigate all of this complexity? If it wasn't complex enough, I mean, we've just, opened up the floodgates on complexity on these patients. And, how do we know them? How do we show them? And how do we advocate for them?
Was there anything else that you'd like to add?
Well, I think there's a number of things that are coming down the pipe from a provider physician perspective, in addition to, MSA, there's Medicare cuts, different than how facilities are treated. Physicians haven't had any kind of patient adjustment. That's another pressure point. And then finally, the health plans are going to address it about senior policies.
Very well said. A lot is going on, and technology has become the name of the game, right? So everyone's talking about AI, automation, it's the solution to staffing, the solution to all these laws. It's not bulletproof, of course. I'm curious, and please jump in where we would like to address it first. What kind of changes to your current technology or new technologies have you invested in?
I'll start that one. So I think what we're looking at is automation. Anything that we can do by way of automation, anything that we're touching multiple times, high touch items, those should be easily automated. But again, really trying to make sure that we are meeting the spirit of this regulatory requirement, and we have such little time to implement just the basics of it. We know that in order for us to be truly compliant, we're probably looking at, do we have to at some point look at our staffing that supports this work? And that will be a delicate balancing act between making sure that we can do all of this work, trying to get there towards automation, but that's in the foreseeable future. In the immediate interim, we're going to have to probably pull resources from other critical areas. So, it's a little bit counterintuitive too, right? Here we have price transparency, we have, hospitals, we need to reduce our cost, and we have something being implemented that is going to increase our cost. Unfortunate.
Well, I think for my group, and we're a multi-specialty physician group, what we've seen an explosion in use is with telehealth and the ability to provide care through telemedicine, both within the emergency department and outside the hospital. So I'm an emergency physician by training, but we provide services through teledoc, so that's kind of the traditional way for providing those services. But we also provide telemedicine for hospitals when we have to triage patients or do what we call rapid medical evaluation for patients when they check into the emergency department. And, that can be done remotely, and the physician can order tests just to streamline the process of getting patients through the department. We've also, providing follow-up care with telemedicine after patients either discharged from the hospital or from the emergency department, to be able to provide that continuity care, because for COVID patients, they really don't have any other mechanism to get follow-up care. They have to be seen where it's not in person.
I think on the front of telehealth, I'm seeing organizations starting to cut back on that direction just based on the lousy reimbursement given, which doesn't, and no disrespect to the payer community, but there's a reason they're publicizing that they'll reduce the premiums on your employees if you'll make them go to telehealth first. It's because it's incredibly inexpensive to administer. We are seeing and using and going down the journey of RPA and AI. I was a little surprised when I moved to the West Coast that some of the technology being AI those things we bought in 1985 that every vendor in the world has called me in the last month to sell me their AI. So we are like many looking for any technology solution, not with the goal of reducing staff, but to just better leverage what we do have as staff and to allocate them in an optimal way. And then when it comes to the digital front door, I was giving kudos to my colleague here. We have a consult. We're a little bit behind in Palomar. We were not doing real well financially until just a few years ago. We're doing very strong now. We're playing catch up in a lot of technologies. A big part of what you do with capital spend and playing catch up. And we had a consulting firm interviewing all leaders, trying to identify what we believe is important. And they asked me about the revenue cycle and CDI, HIM, and some other areas that I work with. And I said, well, let me show you what I think is important. And I pulled out Sharp's my chart and said, this is what we need. And this is what I got in 2016 when I moved here, by the way. So it felt a little embarrassing to say we're really behind. But at the same token, I could give real life patient stories about why I admired that software so much, which I think helps them understand the importance and how we can connect with the public.
That was a really good answer. So I think most of us that are in this industry, one of our priorities actually is creating those efficiencies. And you cannot do that without exploring automation, RPA, and analytics. So I actually created a position, a director position, that's all they do. So his role is specific to performance improvement and operational efficiencies. And in that arena, I think a lot of what we see right now in our industry is all rules-based, which we're able to build the rules if this, then that, if this, then that, if this, then that. So all of the things that are like the claim status and that type of stuff, we built the rules around that. Now we're looking for that next level of where do I get some actual automation that maybe even could happen overnight when nobody's here, and I can take advantage of that productivity when I show up the next day. So I think there's a lot of opportunity in this industry. I think people are still exploring where are you going to get the biggest bang for your buck. And I always say, healthcare is usually the last industry to implement something. We wait for other industries to do all the R&D on it. So once it gets done and everything's good, then we say, oh, you know what? I want to automate my payments. I want to geofence my lobbies so when somebody comes in, we know they've come in. All of those types of things. So it's definitely an area that if you're not thinking about it, you need to, because that's the direction those things are going to go.
And again, I'm all about the patient on this side.
We're about patients too.
Yeah. but I mean, again, leveraging COVID and the transition to digital, and now almost the expectation from patients to receive things electronically. And why do you have to mail my statement? Can't you email it to me? And those things. So I think, UCSD is really putting a concerted effort into our digital patient financial experience. We're going down the road of defaulting my chart patients to paperless billing, having them opt back into paper billing. We do a lot of communication in our business office, or our single billing office, through my chart messaging and email and those types of things. So we're getting away from we're reserving those customer service reps, really building out the self-serve, and then reserving our customer service reps for those really complex calls that really take somebody to handle that patient, again, navigate this complicated system for them. When it's not our fault, that the problems with the insurance, having the time to, I see it. This is, happened to the other day with one of my team members with a physician who called about his insurance, and And my rep was able to see the problem, get the physician on a three-way call with his insurance company, and solve the problem for him. So it's not so much, again, how fast you can, resolve that problem with that patient on the call, but the quality of that call and allowing, my team to take the time to walk them through that process. I think that's what's going to make the difference. And then have your, all your self-serve and as much as you can, build that up so then those patients that are going to go there will be satisfied with that experience as well.
Very well stated, thank you. And you covered some of these in the technology portion, but I remember Winston Churchill once said, never let a good crisis go to waste. And I think, COVID-19 is our crisis that you were talking about in the 1940s. What kind of innovation have you implemented in the last 2 years that you're proud of, that you'd like to share that might not have been a part of the technology conversation we just had?
COVID has certainly been a catalyst for us. I think that our leaders on the front line, they can feel it. They've had to be agile. They've had to pivot quickly, ramp up staffing so that they can help provide the offerings that we need to offer to our patients, to our community. Some of the things that we've done around these COVID vaccination clinics in particular has been finding ways that we can support that work from a virtual environment, making sure that we provide some of those wraparound supports so that registration in particular, an area that I oversee, is not a barrier to the throughput to our patients who are in line waiting to get that critical care. Finding ways that we can front load, finding ways that we can automate, finding ways that we can ease the burden of all of our clinicians so that it's a better experience for everyone. It's a better experience for our clinical team. It's a better experience for our patients. And so being able to come together with our IS team in true collaborative spirit. We've been fast, we've been agile, we've been able to meet the needs of our patients, and I think that's where I am most proud. Is not in just the outcomes, but in also the strong relationships that have been built through this whole entire process.
Of course, the pandemic has resulted in a lot of changes in our practices, and there's been shifts in staffing, particularly when you look at the emergency department, where we saw a reduction in patient volume, where at the same time in the hospital, where our hospitals and intensivists are taking care of patients, we saw an increase in volume. So there's constant adjustments that you have to make to be able to take care of patients during the pandemic. I won't go into the clinical aspects, but that's just some of the challenges we faced.
We, like many, had to adjust to register patients. We all remember March 20, frontline staff without proper PPE, get engaged, get information. It was tough, and I think it was very challenging, and long-term effects of that are still unknown. We have invested in that aspect, but also we recognized very early on what the financial impact of that would be on the pandemic and just volume shifts. We ended up, like many, pulling the trigger on layoffs, but on the technology side, started to look at how we engage vendors and what technologies we're getting, look at the contracts, aligning follow-up activities with claim rates, and started to carry things a little better to shift the cost. And we took our patient statement, because ours is outsourced and has been outsourced forever with the Palomar, and we redesigned that so that our patients coming through the process would go into 4 different work streams. They had been recently unemployed, they automatically go into a group that would help fund their premium. They had eligibility for Medi-Cal or a charity. We have a whole group of advocates that would process them through the spot or registered. And then we used our partner that we're using Experian right now. They designed a pay process so that anybody on a high propensity to pay is flowing automatically. So all my statement costs are just PAC costs and testing costs at Palomar. So the only contingency rate I have is non-COVID, non-Medi-Cal, non-high propensity pay, low propensity. And so it cut our costs by 250% on the collection side, but it also improved our collection rate with 300% on the payment side. So it was really putting those patients that needed help where they belong. So we couldn't do that without the technology. And so it was great value in how we manage the business. But as I said earlier, there's a whole digital opportunity that we're really just embarking on. It's exciting, can't wait to get there, but it's always impressive to see those organizations that are using it today.
Well, the biggest thing that COVID did for me, at least in my work area, was really put us in a position of trying to figure out how to manage that work from home employee. It's been like the one thing that I'm really worried about, but also want to make sure that employees know that we're still there for them, that they stay engaged with the organization, that they still have a feeling of culture that we've tried to build and spent so long creating. So we have, I think some of you know, we have a gamify overlay of our workflow that picks up the tasks that an employee does and point values them. So the innovative thing we did was we actually took that and created a almost real time, every 15 minutes, productivity monitoring tool for our employees that actually lays out a spreadsheet and can go across your screen. And if an employee is meeting their productivity standard, it drops in green. And if something's happening, you get red boxes by that employee, not to do anything other than maybe call the employee and say, did something happen? Is your internet down? What's going on? Can I help you with anything? But it allows that employee to know that they're still part of your organization and you're still there to support them. And I thought, I don't know, the work from home is, I know Basak knows, I'm really worried about the work from home. In any event, that was like the one thing we did.
I'll have to echo that too. From a customer service perspective, when the pandemic hit, I think what I'm very, very proud of, within 2 weeks, I had my entire customer service team working from home and answering calls. And I can't tell you the amount of patients that the first thing out of their mouth when they called was, "Thank you for answering the phone," because they were lost. They were just lost. We use Cisco Finesse. We've implemented, some real-time Tableau. We can take the information from Cisco Finesse, drop it in Tableau. It's almost real-time. I think it is 15 minutes as well. And it will tell the employee. We don't count, the number of calls that the employee takes. Again, we want quality over quantity. So we're asking that employee to be in ready status 65% of your day. So I'm taking out their lunch and their breaks. We give them a little admin time in the morning to work their work queues and call patients back. But we manage their ready status as part of their productivity, because if you're not ready to answer the phone, you're not productive. So putting together that technology to manage productivity from work from home, I think, we had just a blip, and we were back, meeting our goals, and we do the daily engagement system. So we have a team huddle, a Zoom team huddle at 8:10 every morning. I've made a virtual huddle board, and everybody's involved in operations, but just so the employee knows, what they're doing, and again, that we're there for them. We've got teams, we can interact. They got an escalated call, they can still get it to us. So it's almost, we haven't even kind of skipped a beat. But patients being able to know that when they pick the phone and dial our number, somebody's going to be on the other end to answer.
Thank you. I'm going to shoot two questions in order to stay on this content about work from home. John, have you done any what was discussed, what are the pros and cons, and how are you handling for the employees who are in-house the OSHA requirements? Alicia, can we start with you?
Certainly. So our teams have been privileged to have certain groups work from home. We are considering it a professional privilege, so you have to meet certain criteria to be eligible for work from home. You have to maintain the productivity, the benchmarks that we're looking for in order to maintain that work from home status. So right off the top, if there's ever a time or an issue that one of our staff is struggling, then we'll work with them. We'll find ways to make them successful. Sometimes that means they need to come back into the office environment for a period of time so that we can kind of level set so they can go back to that remote work environment. That has happened very infrequently. Really, really happy with the remote work program. We've seen some of our productivity increase tremendously because they don't have some of the same distractions. Sometimes there are other distractions from home, but it has been a really successful program for us. It's offered some of our staff that work-life balance that I think they've found very helpful for them. That sometimes they didn't even know that they needed it as much as they've thrived in that environment. So it's been a very positive, very successful thing. I think that managing in the office environment, we have cubicles within our area, so we're able to space out our folks in a way that meets the requirements. We've been able to move cubicles around so that during the height of the pandemic, we tried to space people out every other cube because not all of our staff were working remote. We kind of had a half-half. So right now we are working towards offering a full remote program, a hybrid program, or a full on-site program. And so our leaders have been able to effectively manage through the various types of programs that we have offered to our staff. And I would say, again, very happy with it, very successful. This is something that COVID was certainly a catalyst. It helped us get to where we knew we wanted to be, but it forced us to get there a lot faster than we anticipated, and it's been a very good thing for us.
Well, as far as running a physician practice, it seems almost normal now to conduct everything by video conference. It wasn't that long ago when we would be meeting in person, but we find out we can pretty much do all of our businesses online now. The only shortcoming of Zoom or having video conferences is the networking opportunities. So if you're going to conferences, there's not that ability to meet people and to network with your associates.
So Palomar, within the revenue cycle, we made a decision to make it permanent. We did it the first time. So we have a pretty solid contract, similar to what you're describing. Productivity drives the need for a level set back in the office. That said, our new space is small enough where all of us, including myself, rotate through. So I'm only on site 1 day a week, and we share offices with other leaders. But we're all on virtually. I will admit, the creativity to engage people in virtual cuddles is a challenge. I'm very fortunate. People know Adam Taylor, who works for me on the board. He gets very creative with Wheel of Fortune, and we've embedded videos, and I appreciate that very much because he helps us get the employees engaged. Another thing about remote that's, I think, changing us in the dynamic of the industry is I was on a panel discussion recently where people are exiting in big numbers to work for higher paying states remotely from the state they reside. And it's becoming more and more problematic for healthcare providers to stay fully staffed and to recruit staff. So it's opened up a whole new paradigm of challenge that we haven't anticipated through these moves.
I think I can say that pretty much everything Scripps does is how we're managing the work from home environment. And I'm actually going to say I'm assuming that everybody else on the panel had this too as a protection. We actually required vaccinations for all of our employees. So we do have a mandated vaccination policy. And if you choose not to be vaccinated, you have to test twice a week.
Yep, we have the same thing, mandated vaccine or an exemption. Yeah. You have to test twice a week. You have to be masked at all times. I have a very small group of people who want to work in the office. Thank gosh, so I'm not there by myself. Again, we space out, and leadership rotates sometimes. But what we've done, UCSD, we have a work from home agreement, and our employees have to sign. It's only good for 1 year. And again, it gets reevaluated year after year, but there's a clause in there that upon the leadership's discretion, we can terminate the contract. And if what they're working from home, if it is having an undue burden on the operations of our office, like, one employee's internet is not connected for some reason, at least 4 hours a day, we can say it's imposing an undue burden on the department, and then they'll have to come back to it.
So we see some line questions that align with the question that we had, so I'm going to relay that. And I'll stay with you if you don't mind, because I know that in your presentation, you wanted to talk about the patient billing guidelines, how they're related to some of the things that HFMA is doing, and maybe talk a little bit about also, in addition to that, the independent dispute resolution, who's handling it on your end, and the IDR process.
Oh, the IDR. We didn't know that. Don't have anybody doing it. And that's, unfortunately, that actually is the truth. We don't have, that's something that we're going to have to put into place now is the infrastructure in order to know if we need to engage in that process. And then again, some of that can come to us from the payers, if I'm not mistaken. They can do that. But for the self-pay one, that's the one that I think we're most worried about is how do we, because again, you're going to have to prove medical necessity and things like that. That's out of the realm of customer service. So, I think that's a conversation there that we haven't had yet. That's something that we're going to have to put the infrastructure. I'd be interested in hearing, again, what others are kind of doing to support that activity. But from the insurance piece, we have not had a payer reach out to us to engage, nor have we taken the opportunity to initiate engagement with the payer so far. So, but the one thing I wanted to bring to your attention when I was doing some research, again, I do a lot on the California Hospital Association website and the American Hospital Association website. And so when I was doing some of my research, I came across a letter, Carmela Coyle, I think is how to pronounce her name, Coyle. So I apologize, Carmela, if I pronounced it wrong. But she's the CEO. She, on November 11th, posted a national pledge on billing will affirm California hospitals' commitment. And she's asking all California hospitals to sign it. I think there's only 60 of us out of the 400 so far that have done so. So we got to get on that right away. But she says in her, earlier this week, I shared with California hospital CEOs and other hospital leaders a request to sign a pledge from the American Hospital Association committing to a set of voluntary patient billing guidelines. And when you click on the link, the billing guidelines pop up, and it's an HFMA resource. And it's HFMA's Understanding Healthcare Prices, a Consumer Guide, HFMA's Dollars and Cents, Patient Financial Communications. So, a lot of these things, just very proud being part of this organization that to what extent that our work is driving change. So just wanted to kind of give a shout out.
Anyone else would like to talk about our process on the
Well, we've actually had a fair amount of experience dealing with the IDR process. process. And the problem is, it's not all the same. The faced with IDR California is just figuring out if they're making the correct payment. As previously mentioned, what is the average contracted rate? They basically give you a payment, and you have to figure out, is this the right rate or not? And you have no idea. It's a big black box. So that's one of the problems. The second problem is just trying to identify, is it ERISA? Who's actually the regulatory agency that's going to handle the dispute? Is it going to be DMHC, DOI? And if you figure that out, then the next step is, is it cost effective to dispute the claim or not? And as previously mentioned, there is a cost associated with it. In addition to the fees, it's the amount of time that you have to spend having staff file the disputes, and it's not that straightforward. You have to, a lot of cases file online, and a lot of data that you have to provide, and it takes a long time for you to get back. The other issues that it faces, how many disputes can you submit at one time? California does limit you to number of disputes that you should submit, and I think for most of you who belong to the health system, you probably have thousands of disputes or hundreds of disputes at one time. You don't want to just dispute 20 or 30 disputes at one time. And for California, the AB 72 process, unfortunately, when Maximus Municipalities handle these disputes, they basically determine, well, are you paying according to the interim payment standard, 125% of Medicare or the average contracted rate? And they didn't really follow the statutes where you're supposed to take all the other factors into consideration, primarily the gold factors. So it's been a frustrating experience, and it's not because AB 72 works. The impression is that nobody uses the dispute process. The reason that providers don't use it is because of all the things I mentioned. It's expensive, it's not cost effective, and you don't get the result that you're supposed to get. Although I understand now that at least the DMHC process is at least more fair for providers in that they are considering contracted rates in their decision as to whether or not a payment is appropriate.
I don't really have much to add to that other than, it's just one other word placed on abundant personnel to take those tasks on. So, we do have some folks that are earmarked for that, but if it's voluminous, it wouldn't be worth chasing.
We'd already started planning a dispute resolution kind of escalation process at Sharp for something else, downgrade DRGs if anybody's interested. And we just kind of dovetailed this into that same discussion. Really, the biggest thing we were trying to figure out is what's the best way for us to track the timelines so that we can not just miss a turnaround timeline. So that's kind of where we're stuck right now and firming it up. But other than that, we're just dovetailing it into our current process.
That's a great idea. I'm still
Borrow.
Yeah, like I said, I think I already answered those questions.
Thank you so much. And in the next 5 minutes that we have left, I want to take a few questions from the audience. I will start with a question that came through the web, and it was around hiring. How do you change your recruiting strategy? Have you typically hired from other states? Have you made any changes in how we work with health management?
We are not looking to hire from other states. We have some pilot programs that we are kicking off. That is something that we would love to get to, but we are a bit more restricted. So we are hiring from the state of California, looking for some additional strategies, using all of the social media platforms, trying to get back into some recruiting fairs, and that sort of thing. But I think as we get further from the crux of the pandemic and we get more towards a new normal, I think we'll be able to do more of those things. But right now we're definitely struggling from that recruiting standpoint. I think we probably experiencing something very similar.
Yeah, so my group is based out of the Bay Area, so as you can imagine, pretty much anything else outside the Bay Area is going to represent less cost hiring. So we are looking at other parts of the country to support our ministry. So one of the other panels this week, the strategy session, attended by HR executives, and they were sharing some of the recruitment nightmares. And they talk about ghosting and how many people have just not shown up for interviews, accepted positions, not shown up for the first day. And it was a large number. This session was Tuesday morning at 7 a.m. Tuesday afternoon, I had 2 candidates for the district director of patient access we're recruiting for. Neither candidate showed. So, I don't know what the answer, what everyone's, thinking about, but it is difficult. And I know that remote workforce, I don't think we're restricting just in California, but there are some jobs like access leaders that have to be there. And so I don't know what the right answer is, but I do know we're entering an era where it's getting really, really challenging to get employees. And I thought about throwing out the tagline in Palomar Health, more than good weather, but I can't say that.
We aren't deliberately looking for out-of-state candidates. We do interview a lot virtually now, which is a little different when you think you know what somebody's like virtually, and then they show up and you're like, oh, this isn't at all what I thought. But other than that, I think one of the things that leaders are exploring is, if the cost of living someplace else is more manageable than the cost of living in San Diego, and you have a high cost, there's movement out there. It's the right thing to do for me to outsource this book of business to somebody less. We are expensive.
We're not recruiting out of state, but where this work from home actually has benefited me as in my department is it has allowed me to retain some good employees that, we're a military, area. So, their husbands got Florida and one is in New York. Employees, because I could offer them the ability to work from home. So that's where it actually has a benefit.
Are there any questions from the audience here?
I heard a lot of what you guys are talking about. Specifically, since I like to dig into, but I'd love to hear your biggest issues with automation. Doug, I heard a lot of issues surrounding AI. I was just wondering, big pain points that you see with automation. I can be really brief, but my beef with AI is when you're doing redundant RPA activity. That was out in the 80s. I started in 1979, so some of you were born. But that didn't wow me when I realized they were packaging that with a new bow and charging 10 times more than they did. So, for me, it's sort of what Gerilynn described. It's next steps, thinking through, finding an inventory, moving it to the next step, solving an issue and categorizing things and not just, repetitive action. So I think the challenge for me is how do we get there? And our culture from an IT perspective is let's test it in revenue cycle. If it works, we'll go outside of revenue cycle. So
I'm embracing that. I want to see it, but we're not there yet.
I can give you a clinician's perspective. I hate it. It just means more clicks that I have to make when I'm seeing a patient. With all these regulations, the board order CAT scan, and I have to justify the CAT scan. All these guidelines, sepsis, etc. It's just alert fatigue for a clinician, and it just slows you down.
I can tell you my biggest struggle right now, and it's something I ask all the time when somebody presents this to me, is tell me where the biggest ROI is. Because I have a laundry list of things I could automate, but I want to know if I'm going to invest in that, where am I going to have the greatest ROI? And that seems to be the most difficult question to answer.
Right.
Yeah, I'll add that from an operations perspective, always trying to stay a little bit ahead of our peers. When clinical guidelines are changing, making sure that we're able to get that information and digest it, get it into the system so that we can take action on that, will really help us. So we're finding that we're getting more and more denials because it doesn't require authorization, but it may not meet the clinical guidelines, right? And so just being able to take what information is out there and available on our payer websites, but then quickly getting that into our system in a usable, manageable format.
Thank you. I think there is an online question. Would you like me to get it muted?
Sorry.
Okay, I'll take the in-person question.
I know.
Maybe not so quick, but obviously the peer industry is based with the transparency and coverage, right? That's I think for them. And then one of the things that I found out from a TCC conference last week was that they will be automating their files will have to be produced monthly. So then you're going to be in a place where the hospital's files, machine readable files, or the estimators are not knowing. So they're never going to marry up. Do you see this moving, fast forward 3 to 4 years down the line where you're involved in these requirements? And then does that put maybe the employers in a position where they can leverage that data to then go direct?
So I guess you maybe answered my question. Who do you think is pulling machine readable files? Or third parties.
Or third parties. The whole intent of having these machine readable files and price transparency was to disclose to patients what the cost of their care would be. And there's not a patient that I know of that's going into your website saying, oh, there's that machine readable file, and pulling it up and printing it out and sharing with their friends how much services cost at each of our facilities. I don't know when a regulator is going to figure that out, but it's probably the one thing that makes the least sense to me. I don't know that the payer regulation will actually be implemented. I will see where that lands. But at the end of the day, it was when we first posted our charge master. Everybody was afraid of posting the charge master. Oh my God, we're going to post a charge master. Everybody will know our charges. And then that day came, and I looked around, and I was like, well, who's pulling the charge master? And nobody was. So we literally only have, because we count the clicks into our machine readable files, we have, since we posted it, like less than 50 clicks into our machine readable files. So it'll be interesting to see where that lands.
So what about in terms of the patient estimates? Is there the peer that will invest as well? They won't necessarily be behind it. Do you think you're going to be?
If you use an estimation tool that is more current tied to the active CDM, then the estimate will be in line with the payer because it's not the stagnant
data set that you're using on a machine readable file for that period of time. So as long as they're distinctly different, you should eliminate that risk. The other thing that I heard Monday morning was that every CFO in the city of Boston and outside of the city just made the decision they were going to put the files on and turn them on, and so all the hospitals in Boston have the files active. So the question I asked as a participant was, who's in their largest contract period and how's that going? And so far no one is. So I'm just dying to hear someone in a competitive market where they did it, how is that impacting their future contracting?
I like that because when we posted our price transparency file, the first person that came to me was our CEO of our health plan. And they were like, what is this hospital's self-pay rate? They weren't necessarily interested in the other pay rates, but what sort of discounting are you giving to unfunded patients? Because it tends to be pretty deep for most of us. And they went back and they're like, I need to go back to that. Look at that. Because some of us are very, very generous in our self-pay rates, and it's in a lot of cases below the contract rate. So be a little aware of it.
Right, I do have a question that came online. I'm going to read it. So, reimbursement professional. She is getting a lot of bombarded with computing opportunities, getting a lot of offers from outside. And the question is, how are you balancing the threat of forced return to the office versus a potential sudden hit to your internal brain trust, who can work remotely, safely, and somewhere else? It's a tough question. So I'll rephrase the question. We have employees who are working at home or working at the office, and they're being contacted by other employers who are giving them a lot more flexibility. So how do you balance the decision to ask for employees to show up versus potentially having a brain drain? It's a retention question. How do you think about retention? Is how I'm reading it.
I was just going to say we are very flexible already, and the ones don't appreciate that flexibility, we're hopeful to improve.
I like that answer. We at UCSD, in my department at least, we provide a lot of flexibility as well, especially with the pandemic, work from home. We offer different report, schedules. So we allow employees to work 4/10s. They can report at 8, 8:30, 9:30. Our phones are open from 9 to 6 daily. We allow them, because kids are home and, sometimes school calls, I got to pick up my kid. We allow them to clock out, go pick up their kid. They're working from home, so they come back, they log back on, and we allow them to make up their hours until 9 o'clock at night so they can keep their paycheck whole. And at UCSD, customer service is kind of a destination job. We're the highest paid revenue cycle employees at UCSD. So that's a retention, as well. If you've got a doctor's appointment 2 days out, you can ask for a flex schedule where you can go to that doctor's appointment, then make up the time on your day off. So we really allow the employees, for the most part, self-employed to a certain extent, as far as their hours go. We want the work out of them. We want them to be available to our patients. We understand that we're in tough times, and the way that we flexibly accommodate them is going to serve us well as them well too.
I think that's well said. I think that it's more about building the relationships with our staff. We realize that we have to offer that flexibility to stay competitive in our marketplace. We might need to be a little bit more competitive, but I think that that what we're all finding and seeing is that it's a partnership with our employees, and if we can find the balance, if we can find ways to keep them happy and keep them successful in that environment, then we're all going to benefit as a result.
Thank you for that answer. Work from home seems to be a big topic, so if you don't mind, we'll take 2 more questions, but you do have veto power. Are you okay with 2 more questions? I know we're a little over time. Okay, we'll take that question over there.
They're moving from maybe the lowest to the highest paid people in your rev cycle organization, which impressed me when you talked about it the other day. Can you talk about how you sold that to your leadership in the organization and how you justified it?
Well, our patient side is first. So thinking about the billing process, I think single billing office was a project UCSD had talked about for about 10 years is what I'm told. So I was actually hired specifically to build that department. But in doing so, being that face of the patient revenue cycle, and plus with SBO, you got to know, not only hospital, revenue cycle, but physician revenue cycle. You have to know, end to end registration, coding, medical records, how to go find an authorization. With the big role, it comes with big responsibility. I think UCSD, it was just kind of that, perfect storm where they were very interested in making the patient financial experience that differentiating factor at that time, that they were willing to give it a try. But again, when my team answers the phone with those, we can answer those complex questions. We are building trust in those patients. We are contributing to the likelihood to recommend, and all of those good things. And again, that bill is the last impression that patient has on, even the clinical service. They get a bad bill, and it's like, I'm going to go someplace else. But so they were really invested in that process. I think, both from the physician group and from the hospital. So just, and we promised, to increase cash.